The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/UHH860. Downloadable slides and practice aids are also available.
Welcome to this educational activity, the expanding playbook of hepatocellular carcinoma, examining scientific data and evidence with your multidisciplinary team. I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA, and I'm joined by Dr. Amit Singhal from UT Southwestern and Dr. Andrew Zhu from Mass General Hospital here in Boston. So today we'll be discussing the latest developments in HCC and how we can enhance the multidisciplinary care for patients. For the past decade, right, since 2007, Sorafenib was the only drug shown to improve survival in advanced liver cancer, and it's not because of the lack of trying that we didn't have positive data. And I think to consider the role for systemic treatment, maybe you could give us an overview of staging liver cancer and how these drugs fit into that paradigm.
So, when we think of liver cancer, this is typically a disease that happens in the setting of chronic liver injury and often cirrhosis. And so when you think of staging, we actually have to use a staging system that incorporates not only tumor burden, but liver function and ECOG performance status. There are several staging systems that can be used. The one that's actually been incorporated probably most commonly into the guidelines and most commonly in terms of treatment decisions has been the Barcelona Clinic Liver Cancer Staging System, which classifies people into multiple different categories, including 0, A, B, C, and D. And one of the key things we should remember is that if you're found at an early stage, we have curative therapies available, whether that be resection, transplant, or ablation. And these are associated with 5-year survival exceeding 60%. And if you're found at an intermediate stage or liver-localized disease beyond curative intent, then really the main thing is chemoembolization or radioembolization. We're starting to see more data with stereotactic body radiation therapy. And the median survival for these patients is somewhere on the order of 2 to 3 years. But one of the big areas that we've seen the most advances in the last couple of years has been in patients who are BCLC stage C. Those patients who either have vascular invasion, distant metastatic spread, or some limitations in terms of their performance status related to the tumor. And as you mentioned, for many years, for over a decade, all we had was Sorafenib, and now we have multiple agents, both in the first line, second line setting, and many more trials that are ongoing.
So let's go back to the benchmark for systemic treatment, the SHARP study, right? I think we need to start there, one, because it really established the population of patients that should be studied for advanced treatment.
Yeah. So the SHARP trial, as you said, was now published a decade ago. This took over 600 patients, randomized them to either receive Sorafenib at its standard dose of 400 milligrams BID or placebo. And as we've known, we've heard many times over the last several years, this was the first agent to significantly improve survival for patients with advanced HCC. Once again, those with either vascular invasion or distant metastatic spread. And what we saw in this paper was that Sorafenib significantly improved survival with a hazard ratio of 0.69. The median survival in the Sorafenib group was 10.7 months versus 7.9 months for those randomized to placebo.
The thing that struck a lot of people about the Sorafenib study was that response rates were very low, right? Yet it improved survival. Can you give us your thoughts on that and when we talk about molecular targeted therapeutics?
Yeah, so this was the first agent that we ever tested, in hepatocellular carcinoma with a positive, survival outcome. I think, because of the mechanism of action of Sorafenib, I think it's very clear the benefit manifested by this agent was actually not due to the radiological responses, but rather by disease control, disease stabilization. So for a long time, we actually have this very misconception that response rate may actually not be as critical as we would like to see in this disease. But I think it's very clear from the experience of Sorafenib, even though the response rate was low, but it's actually translated into improved overall survival benefit. I still think this was actually a milestone for our field.
Right. So we still cannot cure advanced liver cancer. And so I think the benchmark goal in any cancer clinical study, regardless of disease, is to improve overall survival, but also manage quality of life, right? I mean, can you comment on the side effect profile of Sorafenib and its tolerability and management?
Yeah, so Sorafenib is a tyrosine kinase inhibitor and definitely has some adverse events that can happen. And these are typical of the TKI profile. So you see things like hand-foot skin reaction, you can get diarrhea, you can get some anorexia, you can see hypertension. These things are all predictable in terms of, it's usually the same side effects that you see with these TKI agents. But these are manageable as long as you know about them, you can talk to your patients about them. We know that as you start to use this, these are manageable. The other thing that's been nice because Sorafenib has been around for the past decade is that we've actually had a lot of real-world experience. So we know that the AEs seen in the clinical trial are those that are also seen in clinical practice. Sometimes, of course, you can see new AEs that pop up after a drug comes to market, and that does not appear to be the case as Sorafenib has been used. And further, we've used this in patient populations that weren't actually included in the clinical trial. So, those patients had advanced tumor burden, but they were restricted to patients with good liver function. So typically we grade this using the Child-Pugh scoring system, which uses 3 lab variables and then the presence of ascites or encephalopathy. And those patients in the SHARP trial all had Child-Pugh A or compensated liver disease. But with the Gideon registry study that was done after, we actually have seen experiences with Sorafenib in patients with more advanced liver dysfunction, including Child-Pugh B patients. And Sorafenib appears to be equally well tolerated in those patients with more advanced liver dysfunction.
I think one of the questions is for the Child-Pugh B is, does it improve survival, right? We can say the drug is tolerable, but we just don't know that treating a patient with advanced liver cancer and Child-Pugh B liver disease, if we're actually helping them.
Yeah.
But this is a relevant discussion because the first positive study in frontline was the Lenvatinib study, the REFLECT study. Andy, can you talk real quickly about mechanistically Lenvatinib versus Sorafenib and how the molecules compare?
Yeah, so Lenvatinib is another interesting TKI, right? I think the common target that they all inhibit is really VEGF R1 to R3, particularly VEGF R2. But in addition, Lenvatinib also inhibit FGFR 1, 2, 4, which I think clearly may actually have a unique feature. So I think if you just look at the target inhibition profile, I think Lenvatinib definitely is distinct from Sorafenib in that sense. And I think as you will discuss today, I think all the TKIs, they all share the common VEGFR inhibition, but they all differ in other spectrum of target inhibition.
Walk us through the REFLECT study, its endpoints, its patient population.
Yeah, so the REFLECT study was a non-inferiority study, which is something that was new to HCC in terms of its study design, but it took nearly 950 patients, and the patient cohort was once again very similar to what we saw in the SHARP study, patients with advanced tumor burden, but with good liver function. There were some restrictions that were present in the REFLECT study that were not present in the SHARP study. So this study excluded patients with greater than 50% liver involvement, bile duct invasion, or extensive main portal vein invasion. So those patients were not included in the study. These patients who were then randomized to receive either Sorafenib, once again at that dose of 400 milligrams twice per day, or Lenvatinib at its weight-based dosing. So 8 milligrams if you weigh less than 60 kilograms, or 12 milligrams if you weigh greater than 60 kilograms.
That's interesting. This is one of the first times we see a TKI dosed by weight. It's important to note that the doses used here are lower, even the higher dose for the liver cancer population is lower than the approved doses in thyroid cancer and kidney cancer.
Yeah, so the primary endpoint of the trial was median overall survival. And then there were several secondary outpoints, which I think are very interesting with this drug. But you can see here, once again, in terms of its overall survival, they first checked for superiority. And what we saw was that actually the overall survival with Lenvatinib was not superior to Sorafenib. But then when you check for non-inferiority, this is where it was a positive trial. So Lenvatinib was non-inferior to Sorafenib with a median survival of 13.6 months in the Lenvatinib group versus 12.3 in the Sorafenib group.
So non-inferiority, what does that mean?
Yeah, so non-inferiority really, when you take a look at the size of this trial, this is a very large trial. It's 950 patients compared to many of the other trials, when you take a look at this, have somewhere between 500, 600 patients. And what the investigators here did was actually have enough patients where you can actually have a very tight confidence interval around the survival to show statistically that these survivals are similar. It's not an underpowered study. It's really showing that these two drugs have similar survival.
Right, and I think the measurement is if we look at the upper limit of the confidence interval on that hazard ratio of 1.06, the cutoff was 1.08 to declare non-inferiority. So, you know, if we look at some of the secondary outcomes with this study, there were differences.
And this is where I think that really this, medication, once again, it moved the field. So, Andrew already brought up the point of we used to think with Sorafenib, because Sorafenib improved survival without responses, that we were in a field that we may not ever see responses, and responses may not actually be something to be expected. But Lenvatinib was one of the first agents that showed with systemic patients that you can actually achieve responses. And so first, in terms of progression-free survival, we see a doubling of progression-free survival. Lenvatinib, 7.4 months versus 3.7 months with Sorafenib. And even more interesting, I think, in my opinion, is the responses. And so when you take a look at this, whether you measure this by mRECIST or by RECIST, you see a 3 times higher response rate with Lenvatinib than you see with Sorafenib. So by mRECIST, you see responses of nearly 40% with Lenvatinib and nearly 20% if you do this by RECIST.
Andy, can you comment on mRECIST versus conventional RECIST in the context of this data set?
So conventionally, when we look at the response, we're talking about the changes of the size, right? You look at the tumor shrinkage. But based on the experience that we had with Sorafenib, we know that this drug, actually is cytostatic. In general, we do not change the tumor size after the treatment. And then, we actually made a very interesting observation. So even though the size is not changing with treatment, but if you look at the tumor density, particularly the arterial enhancement phase, that can actually change with treatment, which really actually introduced the concept of the so-called modified RECIST. So the modified RECIST is actually not looking at the size change, but rather looking at the changes at the arterial enhancement phase. So in other words, you're looking at the disappearance of the arterial enhancement after treatment. It's a new concept to assess the tumor activity by the drugs.
So I think what's striking is that the mRECIST, there are differences, but even by conventional RECIST, which is just tumor shrinkage by all traditional measurements, is higher with Lenvatinib. So even though we don't improve overall survival, which we can talk about the challenges, because now with second-line agents and the impact of those and how that can affect OS. So we have drugs that are non-inferior for their primary endpoint, overall survival. There's some differences in progression-free survival response rates. A big distinguishing factor is going to be side effect profile.
Yeah. So when you think of this, these are both TKI agents. We've already heard, that there are differences in terms of mechanism of action. But when you take a look at the possible AEs actually are similar between the two medications. But I think what you see that's different is the proportion of patients who actually, may experience one of those AEs. And so when you take a look at the comparison between Lenvatinib versus Sorafenib, the two agents currently approved in the frontline setting, we see that Sorafenib has substantially higher hand-foot skin reaction, and which is a bothersome AE in terms of patients experiencing this. When we take a look at Lenvatinib, you see higher rates of things like constitutional symptoms, so anorexia, weight loss, which can be observed at higher proportions in these patients. And then the other thing that's worth noting is you see higher hypertension, and then you can see higher proportions of proteinuria, which in part are related to that hypertension.
I think that's something to keep in mind because with Sorafenib, after 10 years, I don't know that I monitor proteinuria as closely as we do now.
Yeah.
That was a great discussion. I think the big question is when you see a patient, what goes through your mind in selecting an option? And I'd ask you and Andy for a quick comment on that.
Yeah, I think that, the way that I look at this, we have two options approved in the first-line setting, and when you take a look at the most important outcome to both providers and patients, the two have similar survival. And so, I don't think there's a right answer. I don't think you can say that everyone should receive one agent or another, and I think that this is really something where you have to take a look at the quote-unquote subtle differences between the medications, and there may be patient characteristics that may make you sway for one versus the other. So I think that, we've talked about the higher response rates that you can see with Lenvatinib. And if there is a patient that you feel like there would be a benefit to achieve response, it may make you lean towards that. We talked about some of the exclusions from the REFLECT trial, and so you can say that there may be less data with Lenvatinib in some subpopulations. It doesn't mean that Lenvatinib doesn't work in those patients, it just means that we currently have less data. Similarly, we have Gideon, which showed tolerability of Sorafenib in a Child-Pugh B patient population, and we don't have those extended data with Lenvatinib. And then finally, we talked about some of the subtle differences in terms of the AE profile, which if you have somebody that has bad hypertension, you may be less likely to use Lenvatinib. If you have somebody who is, a toy maker or something that uses their hands actively working, the hand-foot skin reaction may be more bothersome. So overall, I don't think there's an easy way to do this, but I think that all of these subtle differences between the two drugs have to be considered when you're deciding.
Andrew, would you add
So I totally agree with Amit. I think ideally, you absolutely want to have a predictive biomarker to guide us to choose one drug versus the other. I doubt that we're there, but also it's unlikely based on the complexity of the mechanism of action that we'll ever get to that point. So I think at this point, it will be driven by the response rate that you're seeing with Lenvatinib, but also based on the potential safety profile of the patient that you're selecting. So I will go with those two.
But at the end of the day, I think the approval of Lenvatinib was very important because it gave us another option, and it also is another benchmark for combination approaches moving forward, and we'll talk about that. For all the excitement in front line, there's even more excitement, I think, in second line. And, one of the challenges for us, I think, as we get more systemic treatments is, some patient will present with advanced disease, when they walk into the clinic. But a large percent of patients will be intermediate patients who will get triaged to local regional treatment. And one of the big challenges is, as it relates to frontline as well as second line, right? Because I've often said that in order to get a patient to second line, and the advantage of those treatments, we need to get a patient to frontline, meaning that they're not decompensated. So, Andy, as we turn our discussion to second line agents, you've led a lot of the development here. Could you introduce to us, the patient who is going to be transitioned from intermediate to frontline, and then that cue from frontline to second line?
That's a great question. I think, when we are facing just one drug, in general, that decision is actually not made appropriately just because we don't have options for these patients. But now, we actually have quite a few systemic treatment options. I think that decision is becoming more critical. The decision from intermediate stage transition to the advanced stage, I think is actually very critical in my opinion, just because we're so used to the idea of repeated TAs. I think, our intervention colleagues, interventional radiologists, have done a great job helping patients. But having said that, we do know if they're not showing dramatic response to repeated TAs, I think clearly that's the decision that we should be thinking about transitioning to systemic therapy. And second, I think with repeat TAs, it is very clear that the liver function is also getting compromised with greater risk that these patients may actually have declining hepatic function. With the availability of many systemic treatment options, I think one thing that we all have to do as a community is to make sure these patients will have all the treatment options ahead of them. So I think, the transition from intermediate stage to advanced stage should be made when patients showing lack of efficacy to repeated TAs. I think that's very critical. With regard to the first line to second line transition, that's also becoming a very, very relevant topic. Keep in mind, when the SHARP trial was designed, we actually treated patients beyond progression, as long as they're showing the symptomatic improvement. But now, we're having several second-line and beyond treatment options. I think, in my opinion, if they're showing true radiological progression, we should actually make the decision to consider second-line treatment options.
So that's a critical point, right? Not waiting till their symptomatic progression, right? You can't wait till they have decrease in performance status, elevated bilirubin, ascites, because then the options are limited. And to your point, when we only had Sorafenib, you could argue Sorafenib, unless they were going to go to a clinical trial, Sorafenib until clinical progression. But now, typically in my practice, I image people maybe every 8 weeks, and giving them the benefit of the doubt. A few millimeters growth I wouldn't consider progression, but certainly a new lesion or something that's 20% cut off, something like that. So Andy, why don't you walk us through some of the second-line trials? There's a lot to go.
Yeah, the last 2 to 3 years, have been truly revolutionary, in my opinion, in the HCC field. As we mentioned earlier, for almost a decade, we only had Sorafenib as one drug. But this second-line trial, the RESOURCE study, was truly another milestone in the field. What this study was actually really targeting is patients who actually started with Sorafenib. They were able to tolerate the treatment, but eventually progress. And for these patients, they were randomized to receive the standard Regorafenib at 160 milligrams 3 weeks on, 1 week off, versus the matched placebo. The other thing that I think really speaks the quality of this trial is that they use actually 5 strata to actually really looking at the potential imbalance of all the prognostic factors critical to assess these patients. So these stratifications include the geographic region, presence of macrovascular invasion, extrahepatic disease, and obviously ECOG performance status, as well as alpha-fetoprotein level being low or above 400 nanogram per ml. And the primary endpoint was actually overall survival. So if you look at the data, giving Regorafenib in this setting, when patients actually tolerate Sorafenib but eventually progress, Regorafenib definitively improved the survival in comparison with placebo, from 7.8 months to 10.6 months, and the hazard ratio was 0.63. So, clearly this study demonstrated that you can reduce the risk of death by 37% with the use of Regorafenib. In my opinion, this is truly a breakthrough, And then, we actually, have additional treatment options. I think, clearly we have, the additional data coming from Regorafenib. And, the subgroup analysis really suggests that this agent is really benefiting patients regardless of the specific subgroup, whether defined by etiology, and also, whether the AFP is high or low. So clearly, the drug is benefiting, essentially all the subgroups. And if you look at the safety profile, and I think, pretty consistent what we have known from this agent in comparison with Sorafenib, and also the experience of Regorafenib in other tumor types, this drug, clearly behave as another TKI with known side effects, including hand and foot skin reaction, diarrhea, fatigue, hypertension, and also anorexia. But overall, the experience has been that this drug is actually relatively manageable with regard to the safety profile.
Yeah, I think what was a little surprising was the tolerability in this population compared to its other indication, colorectal. And part of that is the colorectal patients have had a lot of chemotherapy, and these patients aren't as heavily pretreated.
Totally.
And I think it really speaks to the selection of the trial. The fact that they tolerated Sorafenib coming into the trial, I think really does speak to why these patients are maybe able to tolerate Regorafenib well.
But what's striking is this isn't a super selected population if you look at the survival of the control arm, right? I mean, the control arm actually did as well as we'll see in the other studies.
So I think, with the availability of Regorafenib, I think, all of a sudden, we're actually talking about sequencing of 2 TKIs. I think, Richard, you actually performed a very interesting study looking at patients, who start with a Sorafenib, followed by Regorafenib. And granted, this is a very selected population. But I think, you can see that for patients who actually receive Sorafenib, benefiting from that, but eventually fail, and when they were actually sequenced with Regorafenib, For this population, the overall survival is up to 26 months, which is really give us a very different perspective, in the right population. And these TKIs truly benefit these patients.
And that goes to this idea of getting patients before they decompensate and transitioning at the right time.
Yeah,
Totally.
so identifying taste failure, getting them onto first-line therapy, getting them through first-line therapy successfully, staying a Child-Pugh A, so then you can get onto second-line therapy. It's
Absolutely.
critical.
And there's no doubt that we need to do a better job of identifying patients with cirrhosis, identifying patients with early HCC, and all the way down the pipeline of identifying patients.
And granted, it's a selected patient population, but I find these data to be very helpful when I'm talking to my patients. I remember, when we had only, Sorafenib as a single agent, there used to be a little bit of skepticism.
Yeah.
In the sense of like, oh yes, it improves survival, but it's still only 11 months. And now, really with good management, early, transitions at the appropriate time, we can start to say that we're starting to see really meaningful survival with appropriate sequencing that exceed 2 years in good patients.
Absolutely.
So who is the good patient for Rego, Andy?
Well, I do think that, patients who start with the Sorafenib, tolerating well, and may actually getting the benefit, for prolonged period of time, i.e. beyond 4 months or 6 months, and then, eventually they progress. Personally, I do think this fits the profile very well.
And there's other options. Why don't
Of
you
course.
bring us through those?
So I think, we do actually have, another second TKI. This is actually Cabozantinib. This is actually another very interesting drug. So if you look at the target inhibition profile of this agent, in addition to the VEGFR2, this agent also inhibits the c-Met, the AXL. These two targets potentially also critical for hepatocarcinogenesis. So in the landmark study of the SELECTRO trial, and patients who fail Sorafenib, but also they actually allow up to 2 prior regimens. So there are actually about 1/3 of the patients actually failing 2 prior regimens. Patients were randomized to the standard dose of Cabozantinib at 60 mg daily versus placebo, with overall survival being the primary endpoint. And this study also definitively demonstrated the improved survival in comparison with placebo. Median survival was improved from 8.0 months to 10.2 months with a hazard ratio of 0.76. So again, the drug can actually reduce the risk of death by 24% with the introduction of Cabozantinib. If you look at the progression-free survival, I think this agent definitely also improved the median PFS from 1.9 months to 5.2 months. And again, with a hazard ratio of 0.44.
I think that curve is very striking, and
Totally,
it has the same
Yeah.
slope for many of the second-line studies. That group of patients that drop off very quickly, and that
Totally.
clearly is attenuated
Yeah.
with these drugs.
I think, if you look at the subgroup analysis, I do think that this agent, seems to be actually benefiting essentially all the subgroup. And I think, if you look at the etiology, for the HBV subgroup, and Cabozantinib definitely, benefiting from this group. And for the hepatitis subgroup, maybe the number of patients is a little bit more on the modest side. For this subgroup, the benefit may not be as striking. But overall, I do think the drug benefiting from all the subgroup patients. And when you look at the safety profile, again, we're very consistent with other TKIs that we have known. Again, the drug, we definitely have the hand and foot skin reaction, hypertension, some abnormality with liver transaminase, fatigue, diarrhea, asthenia, and also decreased appetite. But again, it's still manageable, with careful monitoring, in my opinion.
And again, the response rate with this
On the
drug,
low side.
like Rego,
Yeah.
single agent, yet improving survival.
Yeah.
Let's talk about a theoretical patient, right? Patient presents with an advanced HCC with portal vein invasion or branch portal vein within the liver, no extrahepatic spread, Child-Pugh A, AFP is 200. And this patient gets started on Lenvatinib, right? Front line, is on for some period of time when they have radiographic progression. Amit.
So, really what we have then is you have 2 different options that Andrew already talked about. You have Regorafenib and you had Cabozantinib. Regorafenib, as we've heard, is really in patients who tolerate Sorafenib. And, given the similarities in terms of the structure, I would argue that really the patient selection in terms of tolerating Sorafenib, I personally do feel like that's important when going on to Regorafenib. And it's at least unclear to me if being on Lenvatinib and tolerating that would allow you to have that same AE profile with Regorafenib. I personally would feel much more comfortable in terms of treating that patient with Cabozantinib. Once again, understanding that lack of data doesn't mean lack of efficacy. It doesn't mean that Regorafenib won't work in that patient population. But I probably would feel more comfortable with Cabozantinib.
And that's driven by safety, tolerability.
Exactly.
Andy, what are your thoughts?
I think so. We don't have clear data guiding us because all the data that we have generated for second line are based on Sorafenib failure. So I think when you ask for Lenvatinib failure, first line, progressors, I think we're facing tremendous dilemma. What would be the best decision? I think in that sense, I do actually agree with Amit. Directly going to Regorafenib, perhaps doesn't give you the advantage of testing the prior tolerability of Sorafenib. So in that sense, I think Cabo, definitely will be a very reasonable starting point. But having said that, as we see from our clinical experience, these patients will probably get exposed to all these drugs at some time during their disease course.
And so when the second line trials were designed, it was really when Sorafenib was the only agent that was approved. And so it is going to be something that we're going to have more and more data coming out over time as, in terms of Lenvatinib and what is or what are the best choices in the second line setting.
Yeah, I would take a little different bent. I think Rego and Cabo, and I don't think you guys said this wasn't it, but I think I would feel comfortable using Rego after Len. If they tolerate Len, then I assume they'd probably tolerate Sorafenib. But I think you hit it on the head. There's progress, right? Thank God we're making progress in this field, and we're not going to go back and repeat everything with Lenvatinib. I think we're going to have to just take it on the data that these drugs work second line, right? And that maybe it wasn't Sorafenib pre-sensitized patients to these drugs, right? These drugs work after a prior TKI. But let's talk about some of our other options.
I think Ramucirumab is actually very unique because it's really distinct from all the TKIs we mentioned. This is a very specific drug. It's a monoclonal antibody. The target is only solely VEGFR2. So for that reason, this is really validating that anti-angiogenic is really a viable strategy. And for this study, we started, with all comers in the first REACH trial. We take patients who either progress or intolerant to Sorafenib, randomized to receive Ramucirumab at the standard dose, 8 milligram per kilo versus placebo. So in that particular study, the intent to treat population, unfortunately, we did not actually meet the primary endpoint of improved overall survival. But interestingly, when we look at the pre-specified subgroup analysis, looking at subgroup patients stratified by AFP below or above 400, and very strikingly, patients with baseline AFP above 400 nanogram per ml, we demonstrate that group showed poor prognostic features. And second, Ramucirumab clearly improved the overall survival in that subgroup. So for that reason, we did a so-called REACH2 trial, looking at patients. All of them have to have baseline AFP above 400 nanogram per ml, and they will be receiving the standard dose Ramucirumab versus placebo. And in that study, we definitively demonstrated the improved overall survival. You can actually reduce the risk of death, by 29%, with a hazard ratio of 0.71. So this is really the first study, that we're actually able to use a biomarker-selected strategy to demonstrate that once you use this strategy, you can actually enrich the clinical efficacy that you're seeing with the tested agent. And if you combine the REACH2 and those, in the REACH study with all the AFP above 400 in the pooled analysis, we consistently demonstrated that the median survival was 5.0 months versus the RAM treatment arm of 8.1 months with a hazard ratio of 0.69. So I think, with these two phase 3 trials, I think the role of Ramucirumab is pretty clear in this subgroup. And for that reason, the drug has been approved very quickly.
So, for example, for that patient we talked about who was on Lenvatinib and progressing, we said their AFP was 200. Clearly, if their AFP was greater than 400, RAM would be the other option, Regorafenib, Cabozantinib, and Ramucirumab. Let's talk about the toxicity of RAM. That clearly is different than the TKIs.
Yeah, I think that's why I mentioned earlier. I think this is a unique drug. So for that reason, the safety profile overall, I think is perhaps better tolerated than TKI. And the unique side effects for Ramucirumab is really hypertension that we're seeing very consistently with this drug. And the other side effects, is really the hyponatremia that we're seeing. And then, we also have, obviously low but real risk for hepatic encephalopathy. But by and large, it doesn't have the rest of the TKI-associated side effects. So I think, for patients who already got the exposure to prior TKI, I do think, RAM presents a very interesting alternative, perhaps with different but also, perhaps better tolerated safety profile.
Yeah, and I think, I particularly would consider this in somebody who maybe didn't tolerate first-line TKI, someone who had a lot of AEs, came off quickly because of that. I think, switching mechanism of action in a patient who doesn't tolerate TKI is attractive.
Well, I think a few things to keep in mind, right? The absolute delta in months from REACH2 was not as big as we expected from the retrospective analysis. But the risk reduction of 0.71 is very consistent with the TKIs as far as the magnitude of benefit. And, for those of us who have been in the field for a while and we have a lot of experience with the TKIs, I know even for a patient who tolerates a TKI pretty well in front line, when they stop it for a few weeks, they feel a lot better, right? Because they just forget it becomes a new normal for them. And I think for patients who have been on a TKI for several months and have done well, RAM is a nice break in that, it's intravenous, they don't need to do a daily pill, they come in every 2 weeks, they get their infusion, and they don't have as much of the GI toxicity. Certainly there's these other things that we need to watch for, but, it's pretty well tolerated, and I think that's a big advantage for the molecule. So, thank you both for going through this second line discussion. I guess when we take this to our multidisciplinary team, right, I think it's important that all the stakeholders understand these data and what we have available. Because it goes back to this initial discussion. Before we had systemic treatment, local regional treatments filled a void. And we even expanded beyond where the data indicated because we didn't have much else to offer. Then there was Sorafenib with a modest improvement in OS, but a first and meaningful step forward. And then we've now talked about phase 3 data with Lenvatinib, Regorafenib, Cabozantinib, and Ramucirumab all in 2 years. It's really striking. And I think the fact that we're doing this program speaks to the volume of data and what to keep in mind.
I think it does go back to that analysis that, you showed when you use Sorafenib, Regorafenib in sequence, you can achieve this, meaningful survival of around 26 months in these selected patients. We believe that this really applies to any sequence of first line, second line. And I think it goes back to this whole importance of transitioning at the appropriate time and really tying this into the multidisciplinary tumor board. So we have become much more cognizant of not only, looking for vascular invasion or distant spread, but Andrew, you talked about failure to respond to taste. And so, I use a lot in our tumor board. The definition of insanity is to try the same thing over and over again and expect a different outcome.
So Albert Einstein.
So it speaks to how smart I am. I think that we're very cognizant now that if somebody's not responding to taste, we're much more apt to switch to systemic therapy. And then once again, you brought up the point of we used to image people at 3 months, and now we go to every 2 months. So likewise, we look for radiographic progression, not small, but notable radiographic progression on first line. So we transition to second, third, et cetera. So we really try to get all of these agents in if possible.
And also, Richard, I think with the availability of all these second-line treatment options, I think the responsibility is still on us. How do you logically choose one versus the other? I think at this moment, other than really some very, very unique profiles that we can actually advise our clinicians, patients. For example, patients who cannot tolerate Regorafenib, they can probably be triaged to Cabo. But by and large, the decision to choose one versus the other is still very much empiric, in my opinion. I think the Ramucirumab definitely has the guidance using the AIP as a cutoff. But I think how to choose Rego versus Cabozantinib, sometimes in clinical practice, it's not as straightforward as you would like. Yeah.
The nice thing is, I wouldn't say there's no wrong decisions, but there's really few wrong decisions. I think as long as you're treating patients, you're not doing the whole let's just put them on best supportive care and for someone who's eligible for systemic therapy. I think you're right that oftentimes you're going to see differences in clinical practice, and you saw that even with that case, where you're going to see people who do this on a regular basis, and you're going to see different ways to approach these patients.
Maybe it's becoming comfortable with managing a specific sequence. And developing some expertise with that. And Andy, you mentioned the term third line, right? Nothing we would have thought about in liver cancer. Clearly, Cabo is the only drug that has phase 3 data in about 25% of patients, so it's not clear what they got second line to get to third line, probably more often investigational drugs, I would suspect. But it speaks to the fact that maybe we can improve survival even in that third line population. And I think we're going to be seeing more of those patients as we select patients better, and there's a better appreciation for all the things we have available. And speaking of all the things we have available, I mean, the big impact in all of cancer medicine in the last few years has been the development of immunotherapies, right? And when we're talking about these drugs, we're probably talking mostly about the PD-1 and PD-L1 inhibitors. These are proteins expressed by tumors that help them avoid immune surveillance, and we know that liver cancer develops in the setting of chronic liver disease. The liver is a very immunotolerant organ by design. Liver cancer, I think, is still viewed as a niche indication, even though it's a major cause of cancer death, and these patients obviously carry the comorbidity of liver disease. So, it was not the first indication for these drugs, but both Nivolumab and Pembrolizumab have approval in second line. They got these indications based on accelerated approval mechanisms with the goal of putting these drugs into phase 3 studies. The first study that showed some efficacy of these drugs is Nivolumab in the CheckMate 040 study, and this has evolved into a larger phase 1/2 study with many arms, but in its initial design, it was looking at the safety of Nivolumab in a population of patients who had had prior Sorafenib and did a dose escalation scheme looking at safety as well as early response indications. And they looked at this initially by etiology with the idea that maybe Hep B patients might have a different tolerability than Hep C versus those that are uninfected. And the piece of this story that got a lot of attention was the response rates, right? Response rates in the 15 to 20% range, which you would say, well, Lenvatinib had response rates in the 15 to 20% range. But what was striking here is the durability of the response, as well as what we've seen for all of us who have used these drugs, whether it be Nivolumab or Pembrolizumab, or patients who look like they're cured, right? I mean, there are patients who have a dramatic response. And reassuringly, the adverse events were quite favorable, right? One of the big concerns was autoimmune hepatitis or liver failure. We didn't see those type of events. The overall frequency of grade 3-4 events was fairly comparable, I think, to the TKIs, if not even more favorable. Certainly, when I see these patients in clinic, the discussion is, well, these drugs can almost do anything to any organ system, right? And it's very hard to predict. With that being said, the incidence of very severe or serious events is not that common, and that we need to watch liver function, we need to watch thyroid function, watch for diabetes, things that can happen with this class, as well as the more common things that can happen in a cirrhotic Child-Pugh population. So, with this data in mind, there were pivotal studies done. The first was 459, which read out at ESMO. Andy, do you want to give us some insights into 459?
Yeah, so this is a study that we've been all waiting for quite a while. As you pointed out, because of the 040 study showing very, very exciting response data, all of us, were very curious, how that's improved response rate can actually translate into improved overall survival benefit. So the study was really designed to answer that specific question. And these are actually studies taking patients with newly diagnosed treatment-naive advanced HCC, randomized to either Nivolumab or Sorafenib in a 1-to-1 ratio. Initially, the study actually was looking at both PFS and OS as two primary endpoints, but in the end, OS was the primary endpoint as the final study design. And so as you can see that, the study definitely is actually recapitulating the clinical experience that we had earlier. In a sense, the response rate was definitely close to what we observed, in the early phase 1b study. The response rate was 15% in favor of Nivolumab, and also the response was durable. If you look at the overall survival, though, I think clearly, the overall survival is showing the trend. You definitely see the median survival in the Nivolumab arm is approaching 16 months, as opposed to Sorafenib, which is only about 14 months. But nevertheless, we did not actually meet the statistical significance. The p-value was definitely above 0.05. So statistically speaking, this is actually a negative study. So it really begs the question that you have the checkpoint inhibitor that definitely showing response rate higher, but also the quality of response is very superb. But on the other hand, if you look at the whole population, in the intent to treat population, that's not translated into meaningful improvement in the median overall survival.
Yeah, this study was really, I think, a shocker to many of us because we had these long duration of responses in these patients who received Nivolumab, and I think the issue that's always come up with Sorafenib studies is Sorafenib helps a lot of people a little bit, right? If we look at the data from 459, the disease control rate with Sorafenib was very similar to the disease control rate with Nivolumab, even though with Nivolumab, much of that disease control rate was driven by response versus stable disease. What was very striking, I think, also in the results from 459 was the tolerability. If you look at the safety profile, it actually was better with Nivolumab as far as grade 3-4 events and just total adverse events, looking at intensity of rash, diarrhea, fatigue, things like that, all seem to favor Nivolumab. Yet, it didn't improve overall survival. Survival in Sorafenib was just under 15 months, 14.7 months. Amit, what does that mean to you?
Yeah, so it's the type of thing where, Sorafenib survival was pretty consistent before this, and this is a big jump up to where we're used to seeing this. And I think it goes to the fact that we have second-line agents now after Sorafenib. And so, once again, it's a quickly changing field in the world we live in. And so when this trial was probably first designed and, powered, they probably assumed the same survival that we've seen in all the other trials. But as you start to, once again, appropriately start to use second-line agents, you're going to see a bump up in that overall survival observed in that Sorafenib arm. And so it really speaks to the difficulty sometimes in terms of conducting some of these first-line trials and accounting for changes in the second-line setting. That being said, it's a trial. It was a trial that's negative, and that's unfortunately, at the end of the day, that's where we have to leave it for now. But I think that, as Andrew was saying, there's a lot of intriguing data here, and I think that what we're seeing with the immunotherapy story in HCC is this is obviously going to play a major role. This is the start of the story. This wasn't the end.
Yeah, so along those lines, we know that 20% of the patients in the Sorafenib arm actually got IO agent at progression, right, to that point. But I think it also reflects the fact that we're managing patients better with advanced liver cancer, right? What's striking in this study is, I thought maybe because of all the excitement about early on IO, that maybe the proportion of patients with earlier stage liver cancer would have been higher, which is maybe why we had a longer survival. But we still see that, I think it was like 75-80% of patients were still Barcelona C. There's always about 20% of patients who are Barcelona B. This is the population you were talking about, Andy, who progress on TACE, clearly aren't Barcelona C with extrahepatic spread or vascular invasion, but they've progressed on TACE, and they are candidates for second-line treatment. And I think all of that plays into this 14.7 months as long as well as your comment about second-line crossover. Now, Pembrolizumab, very similar to Nivolumab. Andy, you led the phase 2 study that was the basis for the accelerated approval, the Keynote 224. You want to walk us through that?
Yeah, so when we look at the activity and tolerability of Pembrolizumab, we obviously designed the phase 2 trial looking at the experience in 104 patients. So very consistent with, the previous, CheckMate 040 study. We demonstrate that this PD-1 antibody also produced 17% response rate, but also, the quality of the response is also very solid, meaning that they have very durable responses. And for that reason, FDA also give the green light for the accelerated approval for Pembrolizumab as well. And safety-wise, consistent, what we have known for Nivolumab, and the drug is also, very well tolerated in this population. We did not see any increased incidence for immune-related adverse events. And also for hepatic dysfunction, this drug, was actually also overall safe. We did not see any immune-related, hepatic events. So I think overall, this is a second PD-1 antibody that actually really shows the very impressive radiological responses in this population with safety profile that's actually incredibly favorable. But obviously, I think the question that everybody's begging for, is really the study that you presented at ASCO, and that's the study looking at the survival benefit of Pembrolizumab in comparison with placebo for patients who failed the standard Sorafenib. I mean, Richard, as you know, this is perhaps the last trial that we're going to use placebo as control. I think if you look at the study, consistent, with what we actually have seen, the drug definitely is improving the median overall survival. This Kaplan-Meier curve clearly shows the separation of the treated arm versus the placebo arm. If you look at the absolute p-value, it's 0.0238, but on the other hand, it's actually just missing the predefined statistical threshold of the p-value at 0.0174. So I think, strictly speaking, this is a negative study per predefined statistical threshold. But on the other hand, if the study definitely demonstrates the drug, is active and also is reducing the risk of death by 22%. So this is really a very interesting study for all of us to digest, how do we really assess the clinical benefit of this class of agent in this setting, but also, as we design further studies, and whether, the endpoint should be considered differently using this class of agent.
I mean, from a hepatology standpoint, a lot of the combinations are showing an increase in grade 3-4 events for AST and ALT. How do you interpret that, the significance of that? Some of these patients start off with an elevated AST and ALT just from having chronic liver disease, and then it goes up. Can you give us some guidance?
Yeah, so I think the first thing is when you're taking a look at the immunotherapy in the setting of HCC, once again, you raise the point that this often happens in the setting of chronic liver disease, if not cirrhosis. And so these patients can start with an elevated AST or ALT. And so first, the cutoffs in terms of interpreting an elevated AST and ALT are different in the setting of HCC than they are with other cancers. And the threshold at which you start steroids and other agents would actually be different in HCC. And so it's important to actually take a look at the package insert to see those different cutoffs and when you should start steroids, when you should discontinue. But I will say that, this is something that needs to be watched carefully. Even though it's rare, we do know that if you have a flare of the underlying hepatitis and you develop immune-mediated hepatitis, if you see large flares, that can actually then result in long-term liver dysfunction and can actually then not only preclude further therapy, but actually kill the patient. So I think it's you have to be very cognizant, albeit rare, to follow these patients, follow the AST and ALT, and start steroids at the appropriate time.
Let's talk practically, right? And in my experience, once the bilirubin starts rising, that's not a good thing, right? So if you start seeing an increase in AST and ALT at a rate that, tripling after shortly starting, I think for me the first thing is rule out disease progression, right? Image. And even consider a biopsy. Andy, do you end up doing a lot of biopsies on these patients or not so much? Or?
We actually do. In our center, we're very aggressive looking at the etiology, what causes the transaminase elevation. I agree with you, you have to rule out disease progression. But having said that, I think immune-induced autoimmune hepatitis clearly is on the differential. So for reasons that if you rule out the obvious causes, disease progression, flaring of hepatitis, if you still don't have a clear answer, I think the biopsy should be actually in order.
So, Amit, I'm not a hepatologist, but in a multidisciplinary program over years, you pick up some pearls. Because, Andy, you mentioned autoimmune hepatitis, but there's also just drug-induced liver injury, right? I mean, and the management of those are going to be different, right?
Yes. And that's where the biopsy can sometimes help you, albeit actually on a biopsy, it sometimes can be even difficult to tell drug-induced liver injury from an immune-mediated event. But I agree with you that obviously that's where if there's any question, then I think it's going to be better for you to get an early biopsy. The longer you wait. So if you start steroids, then you've altered that biopsy. It makes it even more difficult on your pathologist to then interpret this. So I think that you're right. If there's any question, then I think that you do a biopsy. If you really think that this, walks and talks like a duck, then treat it like a duck. And so then, if you treat it with a PD-1 or PD-L1 and you start to see this, you don't have other alternatives. I think it's also reasonable in those cases to treat empirically. But I think the key thing is to start an evaluation plus minus management aggressively and early and not to wait too long.
So that was a great discussion on the data with single agent checkpoint inhibitors. We started with CheckMate 040, the single arm data with Nivolumab, which was the basis for the accelerated approval. Keynote 224, which was the basis for the accelerated approval of single agent Pembrolizumab. And then the phase 3 studies in frontline, CheckMate 459 with Nivolumab, and Keynote 240, second line phase 3 study with Pembrolizumab. So these were negative studies by their statistical analyses, and I think one of the approaches to improve on these data is either to have a biomarker that identifies the patients who really get a benefit, or to look at some combination that just improves the number of patients that do get a benefit. And that seems to be the approach that a lot of new studies are taking, and let's turn to our attention to some of those combination approaches. So one of the approaches to increase the responders with immuno-oncology agents is combinations, right? So one of the combinations that has been looked at in other tumor types is the combination of PD-1 or PD-L1 targeting in combination with CTLA-4 inhibitors. Keeping in mind that the first approval for an IO agent was Ipilimumab in melanoma, and Ipilimumab is an inhibitor of CTLA-4, another one of these proteins that is involved in activation of the immune response. So recently we saw data of Nivolumab and Ipilimumab in combination. This was a safety study primarily, given the side effect profile with Ipilimumab is a little different than with Nivolumab. And this study looked at various doses of Ipilimumab, but consistently there was a response rate in the 30% range. And again, that number keeps coming up as we look at combinations, whether TKIs or IO. And the addition of Ipilimumab did increase toxicity versus single agent Nivolumab, but it was certainly felt to be manageable, and that is the basis for the CheckMate 90W study, which is a new frontline study of Nivolumab and Ipilimumab in combination versus Sorafenib or Lenvatinib. So now doing a dealer's choice type of frontline study, again concentrating on patients who are Child-Pugh A, good performance status. So the other IO combination that's being looked at is Durvalumab and Tremelimumab. Again, looking at a CTLA-4 inhibitor here, Tremelimumab, which was actually one of the first checkpoint inhibitors to be looked at in liver cancer. Several years ago, Bruno Sangro and his group in Spain looked at it in a population of patients with Hep C-related liver cancer. And at that time, there was some concerns about the side effect profile. But it has come back and is looked at initially in this relatively small phase 1 study looking at Durvalumab and Tremelimumab in combination in patients with advanced liver cancer, and had a response rate in the 17 to 18% range and acceptable toxicity. This has led to the Himalaya study. This study has completed accrual and looked at Durvalumab versus Durva and Tremelimumab versus Sorafenib. And again, the primary endpoint here will be overall survival and is based on the idea that dual blockade of various checkpoints in immune regulation will improve activity. So there's also a lot of interest now in other combinations. Atezo and bevacizumab was looked at, and bevacizumab, interesting enough, not too dissimilar to ramucirumab. It's an antibody to the VEGF protein instead of the VEGF receptor. This drug is approved for many years now in colon cancer, lung cancer, and many other malignancies, and has made a resurgence in this combination study with atezolizumab. Atezo is a monoclonal antibody to PD-L1 ligand versus PD-1, which is the receptor for Nivolumab and Pembrolizumab. But needless to say, in this phase 1 study, again, quite striking response rates. Again, this number of 32% with long duration of response, and this is across etiologies. The safety profile seemed to be very consistent to what we've seen with single-agent bevacizumab or single-agent atezolizumab, those autoimmune phenomena, as well as hypertension and proteinuria, which we can see with Bev. And again, responses that are durable, right? That's what differs the IO responses from the TKI responses, is the durability. And as we know, atezo-bev was in a phase 3 study, the IM Brave 150 study, that looked at atezolizumab and bevacizumab versus sorafenib. And there was a press release that this study met its endpoint for not only progression-free survival, but overall survival at the interim analysis.
Results showed the hazard ratio for overall survival was 0.58. The median OS has not yet been reached for atezolizumab plus bevacizumab, compared with 13.2 months for patients treated with sorafenib. Median progression-free survival was also significantly increased at 6.8 months versus 4.3 months, with a hazard ratio of 0.59. Grade 3 to 4 adverse events occurred in 57% of patients treated with atezolizumab plus bevacizumab and in 55% of those receiving sorafenib. Grade 5 adverse events occurred in 5% and 6% of patients, respectively. Also, atezolizumab plus bevacizumab delayed deterioration in quality of life compared with sorafenib.
There's a lot of other combinations being looked at. Andy, Pembro and Lenvatinib.
Yeah, that's another very interesting combination, Richard. I think, this is again following the same theoretical scheme that combining anti-angiogenic with checkpoint inhibitor may actually have, augmented the PD-1 activity. And for mechanisms that were not totally clear, but I think, one of the potential mechanisms is that, the anti-angiogenic agents, including Lenvatinib, can actually modulate the immune microenvironment, really changing the immunosuppressive environment. So in the initial phase 1 study, looking at only 30 patients, including 24 patients at the right dose, that this combination demonstrated a very impressive radiological response data, measured either by the modified RECIST or the conventional RECIST. So for that reason, the study is actually, is expanding its cohort. And this study, also demonstrated that, when you look at the response, you not only see just the general radiological responses, you're also starting to see what we call complete response just with medications. Keep in mind that this concept, is not existing in drug-based therapy in our practice, right? We have never seen complete response with drug alone. Yeah. But now, as you can see from Pembrolizumab in combination with Lenvatinib, but also, with the atezo-bev, we're actually seeing complete response just with the medication alone. I think this is something that perhaps we'll come back to this concept in the future. How can we use this concept to benefit patients more? But with the encouraging response data, the combination of Pembro and Lenvatinib is being examined in the phase 3 trial, the so-called LEAP-002 study, against the comparator, the Lenvatinib as a control arm. This study will also look at the value of this combination with regard to the OS and PFS improvement.
So Andy, the other phase 3 study that we didn't comment on is COSMIC. Can you give us an overview?
So, COSMIC is actually another combination looking at the checkpoint inhibitor. In this case, is atezolizumab, again, PD-L1 antibody. and also in combination with Cabozantinib. Clearly, this is another phase 3 trial looking at the similar scheme, a checkpoint inhibitor in combination with a TKI. And this study is actually 3 arms. And the experimental arm is actually atezo in combination with Cabo. The control arm is Sorafenib as a standard. They do want to actually look at the third arm, Cabozantinib in this case, just for regulatory purposes. They want to examine the single agent activity. And hopefully, this study will also shed additional light whether this combination is a viable, effective regimen as well.
I think what's striking is, and the reason for that third Cabo arm, single agent, is because there isn't a lot of early data with this combination. Correct. It just shows you how fast things are changing in the space. And all of these are frontline studies, right? Because the second line, the control arm is dealer's choice, I guess, right? There's so many options. There's a lot of exciting things going on, and there's interest now in moving these drugs to the earlier stage setting, right?
Absolutely.
We've talked about all the activity in advanced disease. Maybe the real question, as we've seen in other malignancies, is where you can really cure people is in earlier stage disease. So the 9DX study is taken for patients who have a resection or curative RFA, who we know are at high risk for recurrence. As you commented, Amit, all patients with advanced liver cancer who have a resection are high risk, but we know that there are some features that make them even higher risk, such as vascular invasion, large tumor burden. So these are very important studies that could have a far-reaching impact should they be positive. Similarly, the Keynote 937 study is looking at adjuvant Pembrolizumab versus placebo. This is again for patients who had a resection. We know they're high risk for recurrence, and looking at if we can improve recurrence-free survival and overall survival. Not to be left out, but this combination of Durvalumab and Bevacizumab, right? So this is the first combination study in the adjuvant setting, and somewhat insightful, right? I mean, because there was not a lot of data with Durva and Bevacizumab, but they, I think, looked at the Atezolizumab and Bev data and said there was a signal there, and to their credit, launched this study pretty quickly. So now 3 phase 3 studies in the post-resection population. I think that's pretty impressive. Can you comment, Amit, in your population, do you have a lot of patients at UT Southwestern that would go on to a post-resection study?
Yeah, I think it's the type of thing where when you take a look at resection is regarded as a cure. But when you take a look at the natural history of these patients, and we talked to all of them about this, that even when you take a look at all comers undergoing resection, the recurrence rate over the next 5 years is 50 to 70%.
Yeah, right.
So, these studies are, largely selecting patients who are high risk for recurrence, but that's pretty much almost all of them.
Right.
And so, we are aggressive in terms of trying to get patients onto these adjuvant trials because it really is an area that we need to move the bar and improve their overall survival.
I think one of the challenges for those of us in the United States, and obviously there's some geography there, is so many of our patients aren't resection candidates, right, because of their underlying liver disease. And it's important to remember, transplant cures patients, and transplant is done for a lot of patients with liver cancer, and the criteria for that are always moving. So it is important that I think patients are assessed at a transplant center or a surgical expertise center. Now, the other group of early stage patients are those intermediate patients, right? Those patients who get local regional therapy. And for a long time, there's been some rationale about combining things with LRT. Amit, can you build on that a little bit?
Yeah, so when we were used to think in the TKI days, I mean, it's the type of thing when you did your chemoembolization or your radioembolization, you'd often see a VEGF surge. And so the thought was that if you started the TKI around the same time, that you may actually suppress that, you may actually reduce neovascularization, and so you may actually see some synergy between combining this. Now, in terms of the IO, combos, I think it's a little bit of a different rationale. Really, what you're talking then is inducing a neoantigen load that may actually, augment the immunotherapy response. So, I think a little bit of a different rationale between the 2 combos. But overall, I agree with you that the combining systemic and local regional has been exciting, albeit with some unfortunate negative trials. in the past, it's been exciting for some time now.
Right. So, the challenge for us in clinical medicine is, we hear these great ideas based on mechanism, and then the reality is another thing. Andy, can you comment on the reality of these these studies?
So, I think, back in the TKI days, for reasons that you mentioned very, very clearly, we always thought that, if you do TACE, you definitely induce the angiogenesis. So for that reason, if you combine with the TKI with anti-angiogenic activity, you may actually really induce some potential theoretical advantage. Yeah. And for that reason, the right study have been actually performed. We have actually looked at Sorafenib following TACE, concurrently with TACE, looking at patients who have favorable response to TACE, and then randomized to receive Sorafenib versus placebo. And also we have looked at other TKIs like Brivinib in the similar setting. Unfortunately, all the results with the combination trial in the intermediate stage have actually failed to demonstrate definitive improved survival benefit. I think really speaks about how complex designing the intermediate stage trial, but also perhaps the TKI may not be really the right partner to actually examine this particular question.
Yeah, so I think one of the things that we learned a lot from these intermediate studies is the natural history, like in the control arm. And we can see that in this Barcelona B intermediate stage, the natural history is really about 30 months, up to 3 years now, right? And and if you look at patients who have intermediate disease that could then get on to systemic treatment, I mean, probably the disease is getting longer, which means the endpoints, is overall survival the best endpoint, time to progression, PFS, all of this is very complicated. And it's only going to get more complicated as we look at the IO agents, right? I mean, you talked about how local regional treatment, whether with TACE or in this study from the NCI where they did radiofrequency ablation or TACE to tumors in the liver and then gave an immunotherapy approach, they actually saw responses far away from the tumor, right? This idea that you release new antigens, you stimulate the immune system, and you can get some sort of synergy. That's yet to be borne out in randomized studies, but there's numerous studies looking at this approach. We talked about that they're doing these studies post-resection, but now in combination with local regional therapy or with radiation. There's a number of phase 1-2 studies, and even phase 3 studies are planned. There was this small study presented recently just looking at feasibility and toxicity, looking at Pembro in combination with TACE. And I think based on what we know about the IO agents, there shouldn't be any real unexpected toxicities. I think with the VEGF inhibitors, we were concerned about thrombosis or bleeding, but even those went by the wayside. And Emerald-1 is a phase 3 study that's enrolling that is looking at Durva and TACE and Durva and Bev. We had done a study many years ago at UCLA looking at Bev and TACE, again with this idea of inducing ischemia, VEGF surge, can you target that VEGF? And we showed that it was feasible and safe, and we actually showed that we decreased neovascularization with bevacizumab. A lot of stuff going on. I think we've had a great discussion, right? And one of the things is still the importance of that multidisciplinary team. And Amit, you've had a lot of interest in looking at this critically in the literature. Can you, as we wrap up, give us your take on the importance of the multidisciplinary program and the data that supports that?
Yeah, there's actually been a couple studies that have evaluated outcomes in patients who are evaluated in a multidisciplinary setting and comparing that to patients who are treated outside of that kind of setting. And these studies consistently show a benefit to a multidisciplinary approach. And the nice thing is, this is what you would expect. This is a complex disease, as we've talked about, with therapies being delivered by different providers. And you outlined this nicely when we first started. You're talking about medical oncology, hepatology, surgery, interventional radiology, radiation oncology. You really need a big, diverse team that really knows different aspects of this management. And as you start to see patients who have stage migration start at one place and either progress or, now even interesting, actually have a response and may move from, let's say advanced to local regional, you really need to have constant communication. And these studies show that you get more appropriate treatment, you actually get more curative treatment, and most importantly, you have significant improvements in survival. by being treated in a multidisciplinary setting. And I think the data really say that this should be the standard of care for HCC patients.
So it's easier for us to say that. I mean, Andy, you're at Massachusetts General, a pretty respectable place, if not one of the best cancer centers in the world. I mean, how do people do this in the community? I mean, do you have some recommendations? Or?
Yeah, so I think obviously, you're definitely hitting the right point. I think for patients with expertise, multidisciplinary team clearly is the way to go. I think, we benefit tremendously from each other. Mm-hmm. We offer the patients the most curative treatment modality. But having said that, Richard, definitely if you're in the community, I think, the message to the community oncologists is that, if you have the expertise, I think you should definitely try to use that as much as you can. But on the other hand, you also need to know the limitation, and particularly when it comes to evaluating the curative intent treatment options, you don't want to second guess. You want to make sure these patients truly have the curative treatment modality available for them. Yeah. So I would definitely encourage referral to the tertiary center in that sense.
Yeah, and even if it's not, if a patient lives far away, they live 6-8 hours from, a tertiary care center, I think, there's going to be more and more remote multidisciplinary tumor conferences, or even just picking up the phone and calling someone and saying, a brief, curbside of I have this patient, just want to make sure that, this patient wouldn't benefit from that evaluation for, resection, transplantation, et cetera. I agree with you. It's impossible for every patient to come into tertiary care settings, but I think that we're all on the same team here to provide the best treatment options for all patients with HCC.
And we'll be providing your cell phone at the end of the program. But, there's been a lot going on in liver cancer, and it continues to evolve. I mean, I think a big priority still needs to be referring patients for clinical studies. I mean, all of that we've achieved has been by the efforts of patients and families participating in studies, and that still should be a priority. With that being said, many patients aren't going to qualify for a study, and I think today we've outlined several important issues, transitioning from intermediate to advanced stage, starting frontline and what those options are and considerations, transitioning from frontline to second line, the options there, considerations of performance status, comorbidities, adverse event profile, biomarkers like alpha-fetoprotein, and then the integration of immuno-oncology. Even though we've had the negative phase 3 studies with Nivolumab and Pembro in first and second line respectively, those drugs still, I think, play an important role, and we're going to see an explosion of data, I think, in the coming years with the combinations and frontline and other settings. So thank you for joining us. We hope you found this activity informative and useful for your practice.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/UHH860. This educational activity is supported by medical education grants from ASI Incorporated, Exelixis Incorporated, Genentech, Lilly, and Merck & Company Incorporated. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com.